So welcome everybody. Muchas gracias por acompañarnos esta noche. Mi nombre es Arturo Aceves. I am going to switch to English because we have Dr. Lallas and he has a very good Spanish, but he'd rather do it in English. So we welcome to this webinar. We're very happy to have this conversation with you guys again. Just about a month ago, we have another conference with Sanitas and Dr. Daniel Robin from Temple University. We are a company that is owned and represents 10 healthcare systems here in Philadelphia. I'm gonna share my screen real quick. 1 second. And our mission is to provide services for international patients. There you go. So Philadelphia International Medicine exists in the context of Philadelphia, the city of arts and medicine in the United States. 6 out of 10 physicians at some point in their career receive training here in Philadelphia. We are a city that has been for many years on always bringing new treatment and new techniques to save lives, to save patients. We have 7 medical schools, 22 nursing schools, over 100 hospitals, and over 100 universities. And that is why Philadelphia as a city is known as the city of arts and meds. We are owned by the healthcare systems here in Philadelphia, by 3 of them. One of them is Jefferson Health, which is the second largest employer in the city of Philadelphia. They have a fantastic urologic oncology department. They've been doing a lot of research. They are a National Cancer Institute. We also are owned by Fox Chase Cancer Center, Temple Health, and we represent 10 healthcare systems more. What do we do? So we do 3 main things. The first one is obviously to receive international patients. We help them to come. We help them working with their insurance companies, working with their governments and embassies to be able to come and receive complex treatment in here. So we help them with everything, from getting the airplane, to getting the appointments, to getting a place to stay, to get them some almohábanas or pan de yuca whenever they're in here. So we really cater for our patients. The second thing that we do is this type of activities. We do medical education. We have our physicians traveling abroad. Next year, we're gonna try to get Dr. Lallas to Bogota, so we can take him to go get some good calentado, to get some good una bandeja paisa. So it is. Oh, por favor. Un ajiaquito. Ush. So it's kind of a soup, doc. I'll tell you about it later. But the idea is to have this type of opportunities to connect our physicians with physicians in Latin America. I am Mexican and I lived for 5 years in Bogota. And I know of the great quality of physicians that live in and receive patients in Colombia. I know the great quality of Colsanitas and the institution, the prestige of the institution. So for us, it's really an honor to be able to connect both Jefferson and Colsanitas. And the third thing that we do is consulting. We work with different hospitals, institutions, and governments to develop clinics, centers of excellence, and we train also physicians and administrative staff. So thank you very much for joining us today. Thank you very much, Dr. Lallas, Dr. Bolaños. It is a great honor for Philadelphia International Medicine. And I'm going to do now a quick introduction of Dr. Lallas, because he is one of our top physicians in the US for urologic oncology. Dr. Costas Lallas is a professor and vice chair of academic affairs at the urologic oncology department at Jefferson Health, with a broad experience both in academic and clinical areas. Dr. Lallas has led studies in the US and Canada, developing standards for research in urology, robotic adrenalectomy, IB clinical trials, brachytherapy, and other topics. So Dr. Lallas is top-notch physicians around the world, and we're really happy to have him here. And for the people that is going to be watching this recording later in YouTube, we also have Dr. Joana Bolaños, who is the Director of Postgraduate Studies at the Department Fundación Sanitas Medical School in Colombia, in Bogota, with a specialization in pediatrics and a Master of Education. Dr. Bolaños has led and participated in research related to pediatric nephrolopathology, pediatric urinary tract infections, and also has published 2 books related to treatise on pediatrics. So we're very happy to be able to participate in this academic event tonight. And now I'm gonna leave the stage for Dr. Lallas.
Well, thank you very much for that introduction, Arturo. I'm so thrilled to be given the opportunity to lecture everybody tonight. I wish that I could be there as opposed to Philadelphia. It's getting cold here, but still, I guess this is better than nothing. I'm going to go ahead and share my screen. Sorry about the glitch. We are going to be talking about 2 things today, really. Before I get into adrenocortical carcinoma, I'm going to talk about adrenal incidentaloma, which is I'll get into exactly what that means. Really, the objectives of my talk today is going to be to describe the evaluation of the incidental adrenal mass. So both the endocrinologic and its imaging workup of these masses. And then after that, I'm going to discuss the clinical presentation and the treatment for adrenocortical carcinoma. First, for the residents and the students in the group, I'm going to talk a little bit about anatomy of the adrenal gland. As you know, it sits just above the kidney on either side. And even if the kidney does not ascend into the retroperitoneum, the adrenal gland is still in the location it should be in. There are 3 zones to the cortex of the adrenal gland. There's the glomerulosa, the fasciculata, and the reticularis. The glomerulosa produces mineralocorticoids such as aldosterone. The fasciculata produces glucocorticoids such as cortisol, and the reticularis produces sex steroids such as estrogens and androgens. The medulla, on the other hand, derives from neural crest cells, and it has a purely neuroendocrine function. It's only 10% of the adrenal gland, and it's composed of chromaffin cells. And it secretes a lot of adrenergic hormones, such as catecholamines, and other things from tyrosine, such as epinephrine, norepinephrine, and dopamine. So the adrenal incidentaloma. This is, by definition, an otherwise unsuspected mass noted in the adrenal gland on imaging. It's actually almost 9% in autopsy series. Up to 20% of these incidentalomas are actually metabolically active, and the biochemical evaluation is warranted unless there's an obvious myelolipoma on imaging. And a myelolipoma is a benign adrenal mass. And that, by definition, has a low CT attenuation of -10 to -20 Hounsfield units. So what can be some of the symptoms or signs of a hormonal imbalance that could trigger you to think that maybe this incidentaloma is actually hormonally productive? Patients can have substantial weight gain. They can have centripetal obesity. They can have easy bruising or severe hypertension. The way that we describe the patients in the US is they're an orange on a stick, right? Because that's what they look like. They have wasting of their extremities, but they have this centripetal obesity, so they're big in the middle. They can present with diabetes, with virilization, proximal muscle weakness, and finally fatigue. So one of the things that we have to determine if there's a patient who presents with adrenal incidentaloma is it hormonally active or is it concerning for malignancy? So at first, there's a clinical, hormonal, and radiographic evaluation to detect this. What could be happening? Is the patient hypercortisolistic? Do they have Cushing's syndrome? Do they have a high level of aldosterone, which is Conn syndrome? Do they have a pheochromocytoma, or do they have a malignant tumor? And also, it's very important that you take a careful history of other malignancies, because a lot of these patients, if it is a malignant tumor, it will actually be a metastatic deposit in the adrenal gland. As far as the endocrine evaluation goes, again, about 15% of all adrenal tumors are considered functional. The most common is a cortisol secreting adenoma or Cushing's. Less common is a pheochromocytoma. an aldosterone secreting adenoma, which is Conn syndrome, or a glucocorticoid androgen producing adrenocortical carcinoma, which is actually the most rare. And there are many societies out there, international societies, that recommend an initial biochemical evaluation of all adrenal masses, all incidental masses, to exclude a pheochromocytoma, a subclinical Cushing's, or hyperaldosteronism. So, and what these societies have recommended is that the following hormonal evaluations should be assessed in all patients with an adrenal incidentaloma. First, an overnight dexamethasone test to exclude cortisol excess, and next, plasma-free metanephrines or urinary fractionated metanephrines to diagnose or exclude pheochromocytoma. Now, these societies also recommend conditionally that these patients should be screened for an aldosterone-renin ratio to exclude primary aldosteronism, especially in patients with hypertension, direct unexplained hypokalemia. And they conditionally should undergo a sex hormone evaluation and steroid precursors in patients who have a suspected adrenocortical carcinoma. So how do we test for cortisol hypersecretion? Well, there's a couple ways. The first line test is considered an overnight low dose dexamethasone suppression test. Also, they can have a late night salivary cortisol test or a 24-hour urinary free cortisol evaluation. Like I mentioned, the overnight suppression test is considered the gold standard. It's preferred and it has a very, very high sensitivity. You give a dose of the dexamethasone at 11 o'clock at night, and then you check cortisol in the morning at 8 o'clock. Cushing syndrome is by definition a serum cortisol level greater than 5 micrograms per deciliter on this overnight suppression test. Well, what about aldosterone? Almost 5% of patients with new onset hypertension have an underlying adrenal aldosteronoma or Conn syndrome. The classic syndrome presentation is hypertension, hypokalemia, and alkalosis, although 40% of patients will actually be normal kalemic. How do you test for this? You screen with a morning plasma aldosterone to renin ratio. A positive screen is a ratio greater than 20 with an aldosterone or greater than 15. A potassium-sparing diuretic and mineralocorticoid receptor blockers should be stopped 6 weeks before testing because they can actually cause a false positive. A positive screen will should be confirmed with a salt load 24-hour urine study. Although this does not guarantee a unilateral source, and in actuality, it can be very difficult to distinguish a unilateral from a bilateral adrenal hyperplasia causing Conn syndrome, and you may need to use either imaging to see that incidentaloma or adrenal venous sampling in those actual patients. So as far as sex hormones go, about 4 to 5% of adrenal incidentalomas are actually adrenocortical carcinoma. And excess sex hormones are present in almost 80% of these cases. It's not really believed that testing is warranted unless adrenocortical carcinoma is suspected. And we'll get into this a little bit later. These masses are greater than 4 to 5 centimeters, or the patient has really obvious feminization or virilization. You can check for serum DHEA and 17 keto steroids, 17 beta estradiol in men who have feminization, or testosterone in women who actually have virilization. As far as the pheochromocytoma goes, again, 4 to 5% of adrenal incidentalomas are pheochromocytomas. Before you test for this, you need to stop specific medications like levodopa, monoamine oxidase inhibitors, benzodiazepine, tetracyclines, and you should have a rapid withdrawal from clonidine. There are various familial syndromes that actually carry a diagnosis of pheochromocytoma with it. So if you have a patient with a young age with a family history or an extra-adrenal pheochromocytoma, you should really consider some of these syndromes, and I've listed at least some of those down below. So the way to test for a pheochromocytoma, again, you can get a plasma-free metanephrine and norepinephrine, which is what I order, or you can do a 24-hour urine metanephrine and fractionated catecholamines. Metanephrines with has increased diagnostic sensitivity because the metabolism is actually continuous. So let's move on to imaging in these patients. So the primary goal, again, is to distinguish between an adrenal adenoma, a carcinoma, a pheochromocytoma, and metastatic lesions. However, using imaging, you cannot reliably differentiate between a functional and non-functional tumor, which is where the endocrine workup comes up. So when you discover an adrenal incidentaloma, you typically, if the lesion typically has benign imaging features, really there's no follow-up needed. However, if the lesion is between 1 and 4 centimeters in diameter, the recommendations are as follows: 1 to 2 centimeters in patients who do not have a cancer history. It's probably going to be a benign adenoma, and you may want to consider a 12-month follow-up in these patients. Now, in all other indeterminate lesions, you perform a dedicated adrenal CT scan or an MRI or both to diagnose a lipid-poor adenoma, and I'll show what the characteristics of this is. And if it is lipid-poor adenoma, those patients need no further follow-up. Now, if it is not a lipid-poor adenoma, the next step really depends on the clinical scenario. If the patient has a cancer history, you need to consider a PET scan or an actual biopsy of the tumor. Now, if the patient does not have a cancer history, you're really thinking of adrenocortical carcinoma at that point, and you need to consider early follow-up, early surveillance imaging, or even resection in those actual patients. Now, if the lesion is indeterminate and greater than 4 centimeters in diameter, and the patient does not have a cancer history, now you're thinking of adrenocortical carcinoma. You don't biopsy those patients. You take them to the operating room if it is resectable. And now, if there is a cancer history, you really need to consider a PET or a biopsy as opposed to resection up front, although you may be getting to resection eventually. So here is an actual diagram of what I just discussed. You have that incidental mass, which is greater than 1 centimeter. Typically benign lesions, you have a lipid-rich adenoma, which by definition is less than 10 Hounsfield units on a non-contrasted CT scan, or you have a signal drop-off on an MRI. A myelolipoma has macroscopic fat, a cyst has water density, and then like an old bleed has benign calcifications, can be curvilinear or septal. Now, an incidental mass greater than 1 centimeter that's indeterminate, not one of these, but you're not really sure what it is. On a non-contrasted CT scan, it's above 10 Hounsfield units. Then you check for something called washout or signal drop to diagnose a lipid-poor adenoma, and I'll show what that means a little bit later on. However, if you do not get a rapid washout of contrast and you don't get a signal drop, then you start to think of pheochromocytoma, adrenocortical carcinoma, a metastasis, or occasionally a lipid-poor adenoma. Finally, if you have an indeterminate mass that's greater than 4 centimeters, the patient doesn't have a cancer history, now you're thinking adrenocortical carcinoma. However, if there is a cancer history, such as a lung or breast cancer, you're going to consider a biopsy or even a PET CT scan. So here is a list of typically benign lesions. We kind of discussed these already. You have a lipid-rich adenoma, you have a myelolipoma, a cyst, you have old hemorrhage, lesions with benign calcifications, unchanged lesions that don't grow over a long period of time, and lesions that do not enhance. And by definition, no enhancement is defined as less than 10 Hounsfield units difference between a non-contrasted to contrasted CT scan. What is a myelolipoma? If the lesion has macroscopic fat that exceeds greater than 50% of the lesion, the diagnosis of an adrenal myelolipoma can really be confidently made. It's really safe to follow up these lesions because they're considered benign. However, if they get to up to larger than 7 centimeters, or if they're otherwise symptomatic, if they're hormonally active, or if they're complicated by any type of retroperitoneal bleed, then you're considering resection of the myelolipoma. So as far as an adrenal adenoma imaging options, I already kind of mentioned this. You start out with a non-contrasted CT. If on a non-contrasted CT, your region of interest is below 10 Hounsfield units, then you're thinking of a benign adenoma. However, if you do a contrasted CT, you should look for something called washout, which means how long the actual contrast stays within the adrenal adenoma. Benign adrenal lesions, you'll have a very, very fast washout, greater than 50% over 10 minutes. However, metastatic lesions of adrenocortical carcinomas and pheochromocytomas do not wash out that quickly. Also, you can make the diagnosis with an in-phase and out-of-phase MRI. So these are typically benign lesions. In the top left, you have that adenoma, less than 10 Hounsfield units in a non-contrasted CT scan. You have a cyst, which is of water density. You have a cyst with coarse calcifications. Again, that could be an old bleed or an old infection. You have a myelolipoma, which has greater than 50% fat. You have macroscopic fat with a myelolipoma. And then you have a cyst with a septal calcification. And again, these are all considered benign, and you can really do surveillance for those lesions. Now, moving to that indeterminate lesion, 1 to 4 centimeters, where you can't make that diagnosis of an adenoma because it's greater than 10 Hounsfield units on a non-contrasted CT scan. That's 30% of adenomas that are lipid poor. And in order to find out if the lesion is lipid poor, you need to do the CT with contrast to detect washout of the contrast, or even an in-phase, out-of-phase MRI. And this is how you do that actual study. You go from an unenhanced CT scan to a venous phase and finally to a delayed phase. Here is the formula that you can use. And again, if you have an absolute washout, in this case of above 60%, that's consistent with an adenoma. However, less than that, if it's a slower washout, then you're thinking of something a little bit more nefarious. Now, if your non-contrasted, if your contrasted CT scan is indeterminate, or if the patient cannot get contrast, like iodinated contrast, because they have something like a severe allergy or renal insufficiency, then you can do an MRI out-of-phase imaging study. Lipid poor adenomas can be diagnosed with this, and they contain enough microscopic fat to really cause a signal dropout on an out-of-phase imaging compared to an in-phase imaging, really due to the chemical shift artifact. And this is an example of the actual drop-off here. You have the in-phase here, and here you have a drop-off of the signal, and it looks dark. And this is diagnosed as a lipid-poor adenoma in this particular patient. And now moving into these incidental masses greater than 1 centimeter, which are actually greater than 4 centimeters, right? So we already looked at the indeterminate masses, lipid-poor adenoma versus something more nefarious, like I mentioned. Now you have something bigger, and you're thinking of an adrenocortical carcinoma or a metastatic lesion. And this is an algorithm that really describes everything that I just spoke about. And I'll talk to Arturo later on about making these slides available to everybody so you can review this on your own. So let's move on to pheochromocytoma, because these are very, very specific tumors that have their own imaging characteristics. As I mentioned, on a non-contrasted CT scan, they measure measured over 10 Hounsfield units. And on a contrasted CT scan, they actually measure over 100 Hounsfield units. It's a well-circumscribed tumor, and it can actually have necrosis or even cysts. Larger tumors are prone to hemorrhage and necrosis, even they were benign. This is what I learned is the classic sign of a pheochromocytoma. You get a T2 MRI, and it lights up like a light bulb. So that is diagnostic of pheochromocytoma, although it's not really as sensitive and specific as previously thought, because metastatic Ds and adrenocortical carcinoma can also light up on these T2 phase MRIs. Now, if you're completely baffled, or if it's an extra adrenal presentation, an MIBG scan actually can be helpful. So here are some examples of pheochromocytoma. There's that classic light bulb sign on a T2 weighted MRI. This is avid enhancement on an IV contrasted CT scan. So this is greater than 10 Hounsfield units on non-contrasted, and then you give your contrast, and this is going to be greater than 100 Hounsfield units. Now, this is very interesting as far as characteristics of pheochromocytoma on imaging. It's a lesion with cysts in it, which actually I did not know, but this can be the actual presentation. And if it grows quickly and outgrows its blood supply, you can actually see central necrosis. So because of something like this, pheochromocytomas are actually called imaging chameleons, because they look very, very dangerous, especially with the central necrosis, but they're still considered benign. Also, again, if everything else is indeterminate or not conclusive, you can get pheochromocytoma-specific imaging. As I mentioned, there are neuroendocrine cells that express cell membrane norepinephrine transporters and secrete catecholamines and other hormones. And this really is the basis for these MIBG scans, which accumulate within adrenergic tissue, making it very specific for both the pheochromocytoma and a non or along the sympathetic chain paraganglioma. And this is what an MIBG scan actually looks like. You have the adrenal mass here and again here, and then they give the MIBG and it absolutely lights up in the adrenal gland, which is going to be diagnostic of a pheochromocytoma. This is another thing that I learned as a resident, that pheochromocytoma is a 10% tumor, and now this has really been called into question. Really, it's one of the 10% rules is that it's considered only 10% inherited. In other words, only 10% are associated with syndrome, but in reality, more than 30% of pheochromocytomas and paragangliomas are considered inherited, and the inherited ones are more commonly bilateral, extraadrenal, or pediatric, or malignant, really depending on each specific hereditary syndrome. So the fact that the hereditary pheochromocytomas are actually much more common than originally thought, that is the reason why the 10% tumor rule has really fallen out of favor more recently. And again, I mentioned some of the actual familial syndromes down here that carry a diagnosis of pheochromocytoma with them. And I haven't included this in there, but it's very, very interesting because depending on the actual syndrome, that you will see an increase in some of the adrenergic hormones selectively. So some will just produce norepinephrine, some will produce everything, some will just produce a lot of dopamine. So it's actually very, very interesting how the familial pheochromocytomas actually act. All right, so we're going to move on to adrenocortical carcinoma at this point. It is a very rare and extremely aggressive tumor, only 0.05 to 0.2% of all cancers. It arises from the cortex, not the medulla, but the cortex of the adrenal gland. And it can present with a hypersecretion of glucocorticoids, with mineralocorticoids, and androgens in up to 80% of patients. Only 2 to 6% are bilateral, and it can also be associated with familial conditions, all of which I've actually mentioned down here. So as far as the presentation of adrenocortical carcinoma, you can have adrenal hormone excess and up to 60%. What are the excess hormones? You can have hypercortisolism. You can have androgen excess. Those are the two big ones. You can certainly have some estrogen excess, and very occasionally some mineralocorticoid excess. You can have some non-specific symptoms from an abdominal mass. These can actually grow to be huge, and they can be instantly detected for imaging by other purposes. So this can be your incidentaloma. And again, as I mentioned, about 60% of adrenocortical carcinomas are considered functional tumors. On imaging, they're usually larger than 4 centimeters. This is nice to know for the students and residents out there. For a tumor less than 4 centimeters, only 2% are thought to be adrenocortical carcinoma. However, once the tumors get above 6 centimeters, 25% are adrenocortical carcinomas, and over 90% of them are actually greater than 6 centimeters. It has a very heterogeneous appearance on CT scan. You have areas of necrosis, you have hemorrhage with calcifications. It may be punctate, patchate, or irregularly nodular. They look bizarre in the retroperitoneum. The CT scan will show greater than 25 Hounsfield units on a non-contrasted CT scan. And again, you don't have a lot of washout like we mentioned earlier. Like I mentioned on the MRI, you see an increased signal on the T2 phase. You have marked enhancement with contrast administration. And again, you only have very moderate washout of contrast. Now, special considerations as far as adrenocortical carcinoma imaging goes, it can very often spread to adjacent organs and regional lymph nodes. You can have vena cava or renal vein invasion in up to 20% of the tumors. And again, for those tumors where you're not really sure, is it adrenocortical? Could it be a sarcoma or something else? You can do an NP59 scan. There are some imaging pitfalls when it comes to adrenocortical carcinoma imaging. It can have a similar appearance to an adrenal metastasis, and that's why you have to ferret out if the patient has another history of cancer in the actual history that you take. It's very rare, but adrenocortical carcinomas can also have small areas of macroscopic fat. So if you have that large myelolipoma, you're one that can consider resection in these patients. And also very uncommonly, adrenocortical carcinomas may show a relative CT washout in the adenoma range, so a quick washout. So really going by size criteria may be the best thing to do in those second two cases. This is what adrenocortical carcinomas can actually look like. Again, you have that T2 weighted image, so that light bulb with early gadolinium, and you have heterogeneous enhancement with late gadolinium. It kind of looks like cobblestoning. This is a patient who presented with a very obvious renal vein and IVC invasion. This are only certain cuts of the MRI, but this can pose a very, very significant surgical challenge. This is an NP59 scan. Again, you have this tumor up in what looks like it should be the adrenal gland, but they went ahead and got an NP59, I guess, to prove it. Maybe they thought it could be a metastasis, and the NP59 certainly lit up in that area to confirm the diagnosis of adrenocortical tissue. And then you have these scary ones, adrenocortical imaging. And I want you to see, what do these tumors do to the kidney? I mean, often there's a question, well, is it renal? Is it adrenal? In my experience, the adrenocortical carcinomas will push down the kidney parenchyma, right? So it doesn't look like it's invading the kidney. It looks like it's pushing on it. But trying to get in this plane to dissect the tumor off the kidney is almost virtually impossible. So someone who presents with something like this, you're going to take out a lot more than just the adrenal gland. Same thing on this side. I mean, this is on the left-hand side. This thing is huge, right? And it looks like it could be invading the kidney here. This is the renal vein right here. Yikes, right? So this patient, you have very serious surgical considerations here, and you're going to be taking out more than just the adrenal gland when you take this patient to the operating room. So as far as staging goes, you're going to be getting abdominal and pelvic cross-sectional imaging anyway. When you diagnose the actual tumor, you should get a CT of the chest on these patients. You're going to get additional imaging only in cases of clinical suspicion. We typically do not recommend an adrenal biopsy in the diagnostic workup when patients with suspected adrenocortical carcinoma, really, again, unless there is evidence of another malignancy and you're concerned about metastatic disease. As I mentioned, with adrenocortical carcinoma surgery, sometimes it can be very harrowing, extremely challenging. We recommend a complete in-block surgical excision with negative margins. That is key, and I'll show you why in a second. It often requires resection of adjacent organs, very often the kidney. If it's a huge tumor, usually you're going to do an open operation via either a thoracoabdominal or an anterior subcostal incision. Open surgery is recommended for all tumors with radiological suspicion of malignancy and evidence for local invasion, where you're going to have to do these large in-block resections. However, for tumors less than 6 centimeters, which don't have local invasion, a minimally invasive adrenalectomy is a reasonable option, again, if the surgeon has sufficient experience. So this is a paper. Actually, it was a moderated poster presented at the AUA back in 2018, looking at margin status of adrenocortical carcinoma and corresponding that with overall survival. And I mean, as you can imagine, negative margins are going to do significantly better than positive margins. You see a significant deviation of the curves very early on, and it lasts all the way through. So you absolutely want to get everything out, which is the reason why you should have a very low threshold to take other organs. Again, as far as staging goes, you can read this, you can look it up just as easily as I mentioned it to you. So I'm not going to go through everything here, but T2 lesions are greater than 5 centimeters. T3 has local invasion, but they do not invade adjacent organs, and T4 invades adjacent organs. You can have nodal metastases, and you can certainly have distant metastases in this patient. So when you group it into staging groups, there's stage 1, 2, 3, and 4. And it should be noted that more than half of patients who present with adrenocortical carcinoma have stage 3 or 4 disease at the time of diagnosis. So they're going to have a very poor prognosis up front. So I mentioned this a little bit earlier, the argument of laparoscopic or robotic, I do a lot of robotic surgery myself, adrenalectomy versus open adrenalectomy for adrenocortical carcinoma. In the last 20 years, there have been several publications that have come out regarding this. Most of them are retrospective reviews. This is one that I pulled from a Cleveland clinic. Again, the numbers are small because we're dealing with a very, very rare tumor. They looked at laparoscopic adrenalectomy and open adrenalectomy, respectively. And they noted that those who underwent an open adrenalectomy actually had larger tumors, but after you adjusted for clinical stage, the open operation had a lower risk of recurrence and improved overall survival approach compared with laparoscopic adrenalectomy, although in this particular series, the differences were not statistically significant. So, and you can see where the curves separate here on your Kaplan-Meiers. I looked at several other papers, all within this time period, and they all pretty much said the same thing, that certainly minimally invasive adrenalectomy is possible, but you're really worried about local recurrence with this. And if you think you have a locally advanced tumor, something that's not going to come out clean, it's probably better to do it open because you don't want to have tumor spillage. It's a very hardy tumor, and you can see the retroperitoneum. So now going on to locally advanced disease, again, I mentioned that up to 20% of these patients can present with positive lymph nodes. A regional lymphadenectomy should be performed with adrenalectomy for patients who have suspected or proven adrenocortical carcinoma, and really should include positive clinical lymph nodes and periadrenal and renal hilum nodes. So you're going to remove nodes, certainly those that are clinically significant, so they're clinically enlarged, but even do a node dissection when you do your operation, at least for diagnostic purposes. Now, this is a key point that I make here. Individual treatment decisions should be made in cases of T4 tumors, such as those with extension into the large vessels, certainly the vena cava, and it should be based on the surgical team at your institution. They should not be regarded unresectable unless they're deemed that by an expert center, one that sees a lot of this. Personally, when I see tumors like this, when I see tumors that invade the vena cava, I have my transplant surgeons on call or in there with me, because very often it's going to get messy. You're going to get into a significant amount of bleeding, and it's something that they can really help you take on. So for my really, really large tumors, my T4 tumors, I will have help in there with me, sometimes a surgical oncologist, and certainly a transplant surgeon, especially if I think I'm going to get into major vessels. Certainly, unfortunately, there's really no accepted role at this point for neoadjuvant chemotherapy. There have been anecdotal descriptions where you get tumor size reduction going from unresectable to resectable, but in reality, the data really does not bear out for neoadjuvant chemotherapy in this population. Let's talk a little bit about histology and histopathology. This is how you really distinguish between a benign and malignant tumor, especially for those smaller incidentalomas that you're going to remove minimally invasively. Dr. Weiss was a pathologist who came up with his criteria. These are the particular criteria. These are the particular criteria of his grading system. And if you have 3 or more of these, it's associated with adrenocortical carcinoma. Here's his original paper that he published in 1984. Again, here are his histological criteria. And these are the difference between positive and negative right here. And if you have 3 or more criteria, this highly correlates with an adrenocortical carcinoma. They went back and revised this system in 2002. Again, not a lot of tumors, only 50 tumors here, with 25 of them benign and 24 malignant. And what they did discover was that the Weiss criteria, so those criteria that I just showed you, they were not equally weighted. Some of them were more prominent and more present in the majority of malignant tumors, as opposed to others. And here is the scoring that you can believe. Again, 24 were malignant, nuclear grade, mitotic rate. Those are present in most of the patients who had a malignant lesion. And you can see there was certainly less like sinusoid invasion and diffuse architecture. So the 5 most reliable criteria that they came up with based on this paper, I've mentioned here, and they used that 5 most reliable criteria with a higher kappa value to build a modified scoring system. And I've mentioned the scoring system down here. So there are some pitfalls with the RICE criteria. There should be special attention paid to histologic variants of adrenocortical carcinoma, such as oncocytic tumors, which because of their specific tumor characteristics will always have a Weiss score of at least 3, whether they really are benign or malignant. Also, Weiss criteria do not really apply to pediatric adrenocortical carcinoma. There is a biomarker that's available that is extremely prognostic for adrenocortical carcinoma. It's called Ki-67. It's a biomarker that's associated with tumor proliferation and growth. The Ki-67 immunohistochemistry has been proposed for prognostic purposes in adrenocortical carcinoma. And the threshold that they use is about 10 to 20% of cells that express this. And if it's above these levels, that's consistently associated with a poor prognosis. And this biomarker is so well accepted that it's been recommended for every resection specimen of an adrenocortical tumor. If Ki-67 immunohistochemistry is not available, a mitotic count may be a surrogate that you can use for prognostic stratification using the criteria that I actually mentioned here. So here's one of the big papers that showed the benefit of Ki-67. It was an observational study coming from a German registry. Big numbers here, 320 patients with adrenocortical carcinoma, and they actually had an internal validation cohort from 3 European countries with 250 patients. And they looked at all clinical histological and immunohistochemical markers and correlated that with recurrence-free survival and overall survival. And you got really, really nice separation of curves, again, in both the initial German cohort and the validation cohort. So the green line on the Kaplan-Meier is less than 10% expression. Then you have that 10 to 20% expression is the yellow line, and over 20% expression is the red line. And for overall survival and recurrence-free survival, you saw excellent separation of all of the curves, regardless of the actual cohort. And they did a multivariate analysis of this population, and they determined that Ki-67 was the single best prognostic value for recurrence-free survival and overall survival in these populations. So again, this is something that can be very, very useful, especially if you're considering some type of adjuvant therapy, and I'll discuss that in a little bit. If you have a patient who has recurrent or residual disease after initial surgery and it's intra-abdominal, you should try to go back and surgically resect that if it's feasible. If you have extra-abdominal lesions, you can even resect those, and then you may want to give some systemic therapy after that. And in all patients, if you're going to give adjuvant therapy, it is recommended to start mitotane as soon as possible. And that's now leading into what's recommended for adjuvant therapy in adrenocortical carcinoma. Those patients who do not have macroscopic residual tumor after surgery, but who have a high risk of recurrence, are thought to benefit from adjuvant therapy, especially mitotane. So here are the high-risk populations. Those who have a higher stage, like a stage 3 tumor, or you have microscopic residual tumor, so an R1 lesion, or if you have a Ki-67 level greater than 10%. Those are the patients who would benefit from mitotane. However, if the patient has less than 10% expression of Ki-67, or they have a lower stage tumor, mitotane actually may be considered overtreatment, which is significant because, as I'll show, mitotane is really, really, really toxic, very, very poorly tolerated. And I mentioned this a couple times already. You want to start this as quickly as possible. Within 6 weeks is ideal for the mitotane. Do not initiate it for later than 3 months after resection. It's thought to be ineffective at that point, and the recommended dosing time is between 2 and 5 years. You can also consider adjuvant radiotherapy to be given in conjunction with mitotane, especially for patients who have R1 disease. I mentioned this already. Mitotane can be very, very toxic. The tolerability is very poor, and as a result, you get a lot of patients who are falling out of treatment, falling out of therapy, refusing therapy, or they just can't tolerate it. And these are the most common side effects that you see with them. Again, I'm going to show what how mitotane works. So its actual mechanism. It destroys cortical tissue, so corticosteroid or corticosteroid replacement is recommended for those patients who are on mitotane. So as I mentioned, mitotane is an adrenolitics agent that selectively damages adrenocortical tissue. Now here's another fact that I did not know that, again, for the students and residents, pack this away because I'm sure it's going to be on an exam or boards in the future. Somehow it preferentially spares the zona glomerulosa, but really destroys the fasciculata and the reticularis. As a result, corticosteroid supplementation is recommended, and the clinical response only thought to be 20 to 40%, but I think you'll get this palliative hormonal symptom relief in up to 70% of patients who you treat with mitotane. You can also try other adrenolitics agents in patients who have unresectable or metastatic disease, metirapone, aminoglutathione, or ketoconazole. These can certainly help also palliate severe hormonal symptoms. And for those patients who actually progress well on mitotane, you can move to chemotherapy. The most common regimen that's given is EDP, and sometimes you can add it to mitotane, and here's the name of that actual regimen. Here is an algorithm that talks about advanced adrenocortical carcinoma. Again, you can do this debulking surgery, and you can give mitotane if there's no prior systemic therapy. Certainly, if it works, you want to continue mitotane for up to 2 to 5 years. If you have recurrence during mitotane, that's when you're going to actually add chemotherapy, and then you're going to look for other salvage treatments if you get failure of all of those. Here is the relative success of all of the other chemotherapy regimens that have been given for unresectable or metastatic disease. And the red stands for progressive disease. Unfortunately, you look at this diagram and you're seeing a lot of red here. So again, this is a very, very hardy tumor, very, very difficult to treat, does not respond to a lot of systemic therapies. There are a couple of clinical trials out there that I know are available that if you can get a patient to a center who has a clinical trial available, that actually may be a possibility for them as well. So what are the main prognostic factors of adrenocortical carcinoma? Again, the stage and the completeness of resection. Again, that margin status, you want to have negative surgical margins. The 5-year survival by stage, really, really poor, even for lower stage tumors. The median survival, at least in this study that I looked at for stage 4 disease, was considered 0% with a less than 1 year median survival. Common sites for metastases: liver, lung, lymph nodes, bone, and you can certainly have local invasion of the kidney and that very harrowing IVC invasion. Okay. With that having been said, I'll go ahead and take questions at this point.
Doctor, we have 2 questions on the chat. The first one will be, I would like to know your opinion on adjuvant positive margins. What recommendations will you give? Radiotherapy, systemic treatment, observation. Thank you.
I would not observe a positive margin, especially for a higher grade tumor or a high mitotic rate or high Ki-67. I would be very, very concerned about tumor spillage. I'd be very concerned about recurrence. So, and in my experience, I don't really see a lot of peritoneal carcinomatosis with these patients. when I've operated on them, if they have advanced disease, usually I'm seeing systemic disease. So they'll show up in 3 to 6 months and they'll have liver metastases, they'll have pulmonary mets. So I'm more of a fan of adjuvant therapy in these patients. And again, you try to get them to that mitotane as quickly as possible because if you wait very, very long, especially for them to get better from the surgery, they may not do, they're probably not going to do very well. So I mean, unless the patient has done very poorly with surgery, I think you're going to want to treat the margins, treat locally advanced disease very aggressively.
Okay.
So I got in an incidentoma less than 4 centimeters.
What blood
Go ahead.
work would you recommend, or just urine sample?
So I kind of showed that already. Again, by all of the criteria that are out there, the recommendations by most of the international societies, you want to make sure that this is something that's not going to hurt the patient. So you're going to look for hypercortisolism, you're going to look for pheochromocytoma, and you're going to look for Conn syndrome, especially if the patient's hypertensive or has hypokalemia.
Okay. The other question is, what is your opinion on PET-CT with DOPA on pheochromocytoma? I think it's dopamine.
I'm not as familiar with it. PET-CT with dopamine on pheochromocytoma. So, you know, certainly the MIBG scans are very useful for a pheochromocytoma or a paraganglioma. And that's, you know, that can be PET. So, but I'm not as familiar with the PET-CT actually with dopamine. I don't know if there's anybody else on the call who may have an answer for that.
I think we opened the forum for everybody. If you can write the comment either on the chat or, yeah, on the chat will be good. In the meantime, I see that Dr. Juan Triana raised his hand. I don't know if, Dr. Triana, do you want me to open the mic for you so you can talk with Dr. Lallas and say your question? Let me see. Dr. Abolaños, do you have another question for Dr. Lallas?
Hi. Well, first of all, thank you very much, Dr. Lallas, for this clear and concrete presentation. It's very interesting. I would like to know, how often do you see this type of cancer in children?
So I'm mostly an adult urologist. So you know, fortunately, the answer is not very often at all. I certainly, I think I saw one when I was a resident, but I don't really see a lot of. I don't really treat children as much. Certainly, it is very well described, and like I said, from what I've read, the Weiss criteria don't really apply as much to the pediatric population. But as far as what I personally have seen, it's just not that common. It's not a patient population that I actually treat.
Yes, I believe it's less than 1%. I believe it's 0.5 or something like that in general.
I mean, that's the problem with adrenocortical carcinoma. I mean, this is a rare tumor. You know, I treat a lot of kidney cancer, prostate cancer, and bladder cancer, and it's not difficult to accrue to clinical trials with those cancers, even in very, very remote spaces, you know, disease spaces, because there's just there's a lot of patients. But with adrenocortical carcinoma, you know, one thing that I was looking for that I couldn't show is what's the survival over the decades of metastatic adrenocortical carcinoma. And I bet you it really hasn't changed that much. And really the only reason why it may have changed and gotten a little bit better is because we've become better at supporting these patients, these really, really sick patients. But these are scary tumors. I mean, I can do a resection that I am absolutely convinced that it's clean, and then I'll turn around and this patient will show up in 2-3 months just completely with fully blown metastatic disease. So these can be very, very challenging tumors.
Okay. There's another question there from Dr. Cardenas. In a larger than 4 centimeter lesion with typical features of a lipid-rich adenoma, what will be your management? So
I think 4 centimeters is small. I mean, but if I saw something 5 or 6 centimeters, I'm taking it out. You don't want to let it get much bigger. I'm not going to wash it anymore. You certainly don't want to lose that opportunity to do a minimally invasive procedure. And again, I do a lot of robotic surgery. I don't do as much laparoscopic surgery anymore. I think that the laparoscopic surgeons in South America are probably a lot better than I am. With the robot, it really has made a minimally invasive adrenalectomy very doable, especially for urologists. So if I have by size criteria, if I have any concerns, I'm going to try to do a minimally invasive procedure, and those things very often just pop out.
Okay, there's another question there. What is the sensitivity and specificity for the NP59 for tumors, for adrenal tumors? I'm sorry, I'm not a physician, and I'm just having...
No. That was perfect, actually, because it's going to give me time to Google the question, right? Yeah. So I'm not really sure. And how many times have I ordered an NP59 study? The answer is 0. I mean, usually, I guess that if you're dealing with something that's extra adrenal, maybe you can get that. But in reality, you usually have a fairly good idea of what you're dealing with, just with conventional imaging.
Okay. Dr. Bolaños, do you have another question?
No, I don't. I really think that it is very useful to everyone here. And I want to thank you again, Dr. Lallas, for your time and for dedicating us all of your knowledge. It's really good. Thank you very much.
I enjoyed it so much, and thank you very much for having me. Like Arturo said, I'd like to be there in person sometime so I can see your wonderful city and your wonderful country. I've actually never been to not just Colombia, I've never been to South America.
You're very welcome here. Oh. You're very welcome. I don't know, we have residents here from radiology and nuclear medicine. I don't know if they have any questions. I see Dr. Caicedo.
Dr. Caicedo.
Fortunato.
I mean, they may have a comment on the NP59 study, because is that something that they're commonly seen in nuclear medicine?
I can open the form for them if they want me to.
Yes. You can talk in Spanish if you want to, and we can translate to you.
Yeah, I'm gonna move Dr. Caicedo to panelist, okay? He can talk too.
And Dr. Humberto Varela.
Humberto Varela, give me 1 second. Let me see where doctor is. Dr. Humberto Varela. There you go. I'm gonna move him to panelist. There you go.
Humberto y Camilo, si quieren preguntar algo, o Daniel Rojas, Carlos Larios, si quieren preguntar algo en español y nosotros traducimos, no hay problema.
There you go. Just moving panelists both. And you can open your mics. I think they're a little bit shy. Doctor Humberto.
Y voy a preguntar.
Sí, señor.
El PET-FDG puede ser pronóstico, dar pronóstico para estos tumores adrenales, o solamente diagnóstico.
Doctora Bolaños, I'm going to need your help with that one.
Good. Can you, por favor, me repites, Humberto, please?
Que si el FDG PET-CT puede ser pronóstico para estos tumores o solamente es diagnóstico.
The study PET can be prognostic or only diagnostic to the cancer.
The which?
So they're asking if the FDG PET-CT scan.
PET-CT scan.
Oh, can it be diagnostic or prognostic?
Yes.
Yes,
I don't know of
fine.
any. I don't know of any prognostic quality of a PET CT scan. So I think it's going to help with diagnosis more than anything else.
With diagnosis only.
Yeah, yeah.
Solo
Okay.
con diagnóstico, Humberto. Considera que desde el punto de vista de pronóstico no hay, sino solamente diagnóstico. Camilo, ¿quieres hacer alguna pregunta?
If you can open your, ¿puede abrir su micrófono, doctor Camilo?
Camilo is muted.
Yep.
Sí,
Doctor, está en
sí,
mute.
a little bit high, I believe. Well, I believe that it has been a
Having some
great
trouble.
evening.
One thing that I will
Yeah.
just mention before we start to say goodbye is for all of the physicians at Sanitas and Dr. Bolaños, and we've been discussing with Dr. Lallas and our physicians here in Philadelphia that this for us is the first step to develop a long-lasting relationship. We don't want this to become just a webinar one time. We would like to kind of find a mechanism for both our institutions to develop a relationship based on the academics, based on be able to help with patients and research. So Dr. Lallas, I'm going to follow up with Dr. Bolaños to kind of find who might be a good communication channel and propose something to you and your team at Jefferson, so we can kind of find some programs, and within that program, the opportunity to take you to dance salsa in Bogota.
Very good.
Or we can go to Cali.
Okay,
We can always go to Cali, but
No,
we can start.
I'll bring the Advil.
You can come to Bogota. You
Yeah,
can come
right.
to Bogota. We can
There you
choose
go.
you, of
Yeah.
course.
And Dr. Bolaños, I know that she's a very good dancer. So
Thank you, Arturo. Thank you very much. I believe that we have many opportunities now to do things together. Research is one thing that we really love to do, and we have an excellent team for that. So, of course, we can join us and see how it works. Good.
Awesome.
well, thank you very much, Dr. Lallas.
Thank you,
I
Arturo.
really
Thank you,
appreciate your
Ana.
time. It's been an honor for us.
Yeah, muchas gracias. Bye-bye.
Dr. Lallas, muchas gracias. Doctora Bolaños, Dr. Valera, Dr. Camilo, and everybody in Bogota, thank you very much. Have a good night, and please stay safe. Stay safe.
Right.
Yes,
Bye.
stay at home.
Cover
Good.
your mask.
Thank you.
Right.
Bye,
Wear
Arturo.
the mask.
Bye,
Bye now.
Dr.
Yeah,
Lala.
so-
Good.
Bye
Good
bye.
to see you.
Bye now.
Meeting you. Bye.